All right, 26 and 27, I think I'll get into this one. Crisis and disaster. So crisis is not defined by the experience itself. Crisis is defined as a struggle for equilibrium and adaptation in its aftermath. So what would a healthy adaptation be? Different things that we may see is, especially going to be in the resilience, which we've talked a lot about. People moving forward and it not killing them or not devastating them to the point that they can't function in life. Crises are usually limited to usually 4 to 6 weeks. The outcome of the crisis depends on the realistic perception of the event, the adequate situational support, and adequate coping mechanisms. Crises are going to be defined by the person themselves, what they consider a crisis. So crisis intervention is a short-term therapeutic response that focuses on rapid resolution of an immediate crisis or emergency using available personnel, family, and or environmental resources. And this is out of your book, Robert's Crisis Model. You can read through this and go from 1 to 7 to see how this model shows us working through a crisis. So you have different theories by these people that are listed here. Albert R. Roberts, his theory is a 7-stage model and crisis intervention, helpful for those in acute situational crisis or with acute stress disorder. Remember, acute stress disorder is the one that happens prior to post-traumatic stress disorder. So what type of patients do we see with acute stress disorder? So somebody who's gotten potentially a terrible diagnosis, somebody who has suddenly lost a family member or a loved one or a best friend, potentially someone who has just discovered their spouse was having an affair. I mean, there's all kinds of different things that patients can lead them to acute stress disorder. And what can acute stress disorder lead to? Well, I just said it. It can lead to post-traumatic stress disorder. So, different types of crisis. So there's maturational crisis. So this is from the Erik Erikson theory. Each stage represents a maturational crisis that is a critical period of increased vulnerability and, at the time, heightened potential. Reaching a new stage, previously used coping skills will not be effective and new ones have yet to be developed. So that's why it's a crisis, right? I get to the next level of Erikson's and I am then, okay, well, trust versus mistrust. Okay, that's obviously a baby, and whatever coping that was used during that is not going to work in the autonomy versus shame and doubt. So each time new ones have to be learned, coping mechanisms, and previously used ones will not be effective. So it's always a learning process. Examples of different events. So leaving home in late adolescence, marriage, birth of child, retirement, death of parent. So these are things that happen, but people have to deal with them. So factors that disrupt successful progression, alcohol and drug addiction, unresolved problems, inadequate support systems, low resilience. I mean, we could go on and on about different things that can disrupt that process. So types of crisis: situational. So these arise from events that are extraordinary, external, and often unanticipated. So examples of a situational crisis would be loss or change of a job, death of a loved one, an abortion, change of financial status, divorce, or severe physical or mental illness. The degree of which the crisis affects a person depends on the support available, the general emotional and physical status of that person, and the ability to understand and cope with the meaning of the stressful event. So really, let me tie this back around because I might have mixed that a little bit. Maturational, that's going to be in some kind of developmental area. So going back to the other slide, like leaving home as an adolescent, eventually the adolescent is going to leave the home, and then there's going to have to be new coping, right? Not had to yet cope with leaving my house, so now I've got to cope. So things that we expect will happen versus extraordinary, external, or often unanticipated. Though we know people around us will die, we're not usually very prepared for it. So death of a loved one, Even an abortion, as controversial as that is, if a young woman finds herself in that position of unwanted pregnancy and going to have an abortion, it is still a situational crisis. That they found an unplanned pregnancy, and now I have to make a decision on, am I going to have this child? Am I going to choose adoption? Am I going to choose abortion? There's so many different things that go through somebody's mind. So it is a situational crisis. So all of these things here that we've listed and talked about are part of that. Adventitious, so unplanned or accidental crisis. So a natural disaster would be in this, like a flood or an earthquake, a national disaster such as war or terrorism, or a crime of violence like rape, assault, or murder. Post-trauma phenomena include acute stress disorder, PTSD, and depression. So all three of these things. So we know acute stress disorder can lead to PTSD, and then also depression for these people. So basically it's totally unplanned and or accidental. Obviously a crime of violence is not accidental for the person who committed it, but it's definitely unplanned for the person who was on the receiving end of that crime. So psychological first aid, also known as crisis intervention, and debriefing for all age groups is very important. So like when a teacher or a child dies in a school, many times they'll have grief counselors that come in to talk with both the staff and other kids. So phases of crisis. Phase 1 is the conflict or problem. The self-concept is threatened. The person has increased anxiety. They must use problem-solving techniques and defense mechanisms, resolve the conflict or problem, and try to reduce anxiety. Phase 2, if the defense mechanisms may fail, if the threat persists, the anxiety increases, feelings of extreme discomfort, functioning is disorganized, so kind of all over the place, trial and error attempt to solve problem and restore normal balance. And then phase 3, if trial and error attempts can fail, anxiety can escalate to severe level or panic. Automatic relief behaviors motorized, so withdrawal and flight, right? So that's that fight or flight, so more of a withdrawal and a flight. Some form of resolution may be devised, like compromising needs or redefining the situation. So eventually it has to come down to, how do you look at this? I mean, is it going to kill you or is it going to get better? Crisis phase 4, problem is unsolved and coping skills are ineffective, which produces overwhelming anxiety, possibly serious personal disorganization, depression, confusion, violence against others, or suicidal behavior. So this is getting to the point, like our nursing diagnosis would be hopelessness. So this 5-phase disaster management continuum, you can read through this. Preparedness, mitigation, response, recovery, and evaluation. Make sure you read through those and have an understanding. So I'm going to get rid of that and move on to the next chapter. If you have any questions about this stuff, you can certainly email me or post them in discussion board. So anger, aggression, and violence from chapter 27. So anger is an emotional response to frustration of desires, threat of one's emotional or physical needs, or a challenge. It is a normal emotion that can be viewed as positive when expressed in a healthy way. Problems occur when anger is expressed in aggression or violence. Aggression is the action or behavior that results in verbal or physical attack. So aggression is not always inappropriate and sometimes necessary for self-protection. Okay, so that's definitely true. Violence is always an objectable act that involves intentional use of force that results in or has the potential to result in injury or injury to another person. So anger is the emotional response. Aggression is the getting into almost like attack mode, right? Or getting into it's a behavior that we'll see that results from the anger, and again could be appropriate, but violence is always an objectable act. We say that we should not result to the violence, but we may have to result to the aggression. So in the hospital, violence is most frequent in psychiatric units, emergency departments, and geriatric units. Most all nurses will deal with violence at some point in their careers. So we've been talking about that, about physical violence, especially in those different areas we just talked about, is pretty common. But verbal violence as well, and it can cause us to have aggression. Comorbidities with anger and aggression and violence, so post-traumatic stress disorder, a patient that has that, or substance abuse disorder, can coexist with depression, anxiety, psychosis, and personality disorders. So there's biological factors, so areas of the brain, neurotransmitters, and just a predisposition all along for that patient. Behavioral theory says that it was a learned response, that anger and aggression is a learned response. Social theory is imitation of others. So I'm imitating what I've seen. Neurological conditions that can be associated with anger include certain brain tumors, Alzheimer's disease, temporal lobe epilepsy, and traumatic injury to certain parts of the brain. And then you have your different traumatic brain injury causes down here. It's FYI stuff. So application of our nursing process, the assessment, our general assessment, anger displayed by patients in the form of increasing demands, irritability, frowning, redness in face, pacing, twisting of hands, clenching fists. So I'm going to be watching all of this stuff to see if my patient is displaying anger or not, right? My own self-assessment is calm responses to the patient that's angry and has potential aggression. So HALT is a really cool acronym to remember. If you're feeling that you're getting angry or aggressive towards your patient, you want to say HALT. Am I hungry, angry, lonely, or tired? These things are underneath things that sometimes we don't pay attention to that can make us kind of lash out or show aggressive behavior towards our coworkers or patients. So you want to ask yourself, why am I acting this way? Am I hungry? Am I angry? Am I lonely? Or am I tired? Our choice of words, our tones, our body language, we have to be very cognizant of all of that that's going on within us. So we're going to skip past that question. So nursing diagnoses for this is ineffective coping, stress overload, risk for self-directed violence, or risk for other directed violence. So over here with our implementation, our psychosocial interventions, we're going to say to the patient, I expect for you to stay in control. When anger and aggression are priority problems, seclusion, restraint, or pharmacological interventions may be necessary. So kind of like we've been talking about quiet rooms or seclusions or timeouts, or giving some kind of medication that will help with that anger and aggression. De-escalation of anger is the primary nursing intervention. Those of you who went to Brighton have got to learn about de-escalation and sit in on a class for that. You want to make sure that you read page 520, Considerations for Staff Safety. This was also in the very beginning of our course that you guys read that. In pharmacological interventions, so I think I've told some of you about, they'll say a B52, so that's 5 milligrams of, that's backwards. You guys change that on your slides. It's 2 milligrams of Ativan and 5 milligrams of Haldol, so that's B52. We're not going to do that. So seclusions and restraints, we've talked about these too, but to refresh, seclusion is involuntary confinement alone in a room where a patient is physically prevented from leaving. This is never to be punitive, not for us to pay the patient back. The goal is safety for the patient and others. And remember, we're going to be assessing those physical needs, like needing to use the bathroom if they need a drink of water. Restraints, any manual method, physical or mechanical device, material, or equipment that restricts freedom of movement, only used as an alternative when other interventions have been tried. We've been talking about that. So intervening in different settings. So caring for patients in general, hospital settings, patients with healthy coping skills who are overwhelmed. So we want to help with that. Patients with marginal coping skills, caring for patients in inpatient psychiatric settings, and caring for those with cognitive deficits. A violent patient is restrained. What is the nurse's first priority? and I'm going to ensure the patient's safety. Which patient behavior is a criteria for mechanical restraint? So screaming profanities, assaulting a staff person, refusing medication, or throwing a pillow. It's going to be assaulting a staff person. All right, got through it with 5 seconds to spare.